All right, welcome to the deep dive. You've given us a really interesting set of sources today.
Yes, we're diving into Thoracic Outlet Syndrome, or TOS.
And specifically, we're looking at those extra ribs some people have
Vertical ribs, right.
and how they can cause problems.
Exactly. And our main guide here is a study from the Journal of Vascular Surgery back in 2018, Jellebert and his colleagues. Plus, we have some commentary from the authors, too.
Okay, and these sources are pretty focused, aren't they? On one specific surgical technique.
They are. They zoom right in on how surgeons handle TOS when a cervical rib is involved, specifically using what's called the transaxillary approach.
Got it. So our mission today is basically to unpack this study. What they find, what does it tell us about managing these patients using this particular method?
That's the plan. And like a lot of medical topics, there's actually quite a bit of history here, some surprising bits, too.
Oh, yeah. Where does the story start?
Well, the idea that these extra ribs can cause trouble isn't new at all. We're talking over 200 years ago. Yeah, 1818. A surgeon, A.P. Cooper, he was the one who first really connected cervical ribs, these extra ribs growing from the neck bones, with symptoms like arm pain, numbness, weakness, neurovascular stuff.
And he called it cervical rib syndrome.
He did. That was the original term.
So they knew the cause way back then. Did they try operating?
Took a few decades, but yeah. The first actual removal of a cervical rib happened in 1861. Surgeon named H. Coote.
And how did he do it? Which approach?
He went in through the neck, what we'd now call the transcervical or maybe supraclavicular approach, basically above the collarbone.
Okay.
And what's really kind of wild is that approach from the 1860s has pretty much stayed the most common way surgeons do it ever since.
Still, even now. That's amazing. But the sources we have focus on a different way in, right?
Exactly. So fast forward about 100 years to the 1960s, you have Dr. David Roos. He was really pushing a different technique.
The transaxillary one.
Yes, going in through the armpit. He initially developed it more for taking out the first rib, which can also cause TOS, but he applied it to cervical ribs too.
And why did he prefer that? What was his argument?
He felt it gave a better view, more direct line of sight to the rib itself, and crucially, he thought it might be safer, less risk of bumping into or damaging the nerves and blood vessels packed in that area.
That sounds logical. Better view, potentially safer.
Yeah.
So why didn't everyone just switch over then?
Yeah, good question. And this kind of comes through in the author commentary we looked at. Yeah. Sometimes it's just, well, custom, what people are used to doing, familiarity.
Habit.
Maybe a bit of that, yeah. Even if a newer technique might have advantages, overcoming that inertia, that established practice, can be tough.
And that's why this 2018 study is important. It revisits that alternative approach with solid data.
Precisely. It brings modern data to bear on that older debate.
Okay, let's get into the study itself then. What's the full title again?
It's Transaxillary Decompression of Thoracic Outlet Syndrome Patients Presenting with Cervical Ribs by Jellebert, Rigberg, and the team. Published in 2018.
And you said it was a bit of a landmark paper. Why?
Well, according to the authors, when it came out, it was really the first paper to describe using only the transaxillary approach for the initial surgery in a decent-sized group of patients with cervical ribs.
So people had used the transaxillary approach before for this, but maybe not exclusively or not in such a big reported group.
Exactly. They point out other big studies on cervical rib surgery, like one by Sanders and Hammonds. They had 39 cases, but all done the old way, supraclavicular.
Okay.
And another more recent one by Chang's group had about 20 patients, 23 surgeries, but they used a mix of approaches, some supraclavicular, some transaxillary.
Right, so this Jellebert study is unique because it's reasonably large and it's purely transaxillary for these cervical rib removals.
That's the key distinction. And in terms of size, for the cervical rib part.
Yeah, how many?
It's the biggest series reported at that time, specifically for transaxillary cervical rib surgery. They included 70 operations, 70 resections, just for symptomatic cervical ribs.
70. That's a solid number. And where did these patients come from?
They were pulled from a much larger database the team had been building for years, almost 20 years, actually.
Wow.
Yeah, tracking over 800 TOS patients in total who'd had over 1,000 procedures between, 1997 and 2016. So a huge amount of background data.
That definitely adds credibility. And how did they structure this specific analysis, the one focusing on the cervical ribs?
It was retrospective, meaning they looked back at the data they'd already collected. But the key thing they highlight is that the data collection was prospective and protocol-driven. Meaning everyone was assessed in a standardized way from the start. They all had the same workup. And for this group, the surgical approach was standardized, always transaxillary. And importantly, they used standard ways to measure outcomes afterward.
Okay, that standardization sounds crucial for making sense of the results.
Absolutely. It avoids that comparing apples and oranges problem you sometimes get.
So let's talk about the people in the study. These 56 patients who needed the 70 surgeries. What were their symptoms mostly?
The vast majority, 49 of them, had neurogenic TOS.
That's the nerve compression type.
Yeah.
Pain, tingling, numbness, weakness.
Exactly. Compression of the brachial plexus nerves going down the arm. The other 7 patients had arterial TOS.
So the rib was squishing the artery.
Right, the subclavian artery, which can cause issues like poor blood flow, the arm getting tired or painful with use that's called claudication, or even blood clots forming.
And the ribs themselves, did they vary in size or shape? Did they track that?
They did. They used a standard classification system from the Society for Vascular Surgery. It basically describes how developed the cervical rib is.
Like how complete it is?
Yeah. Class 1 is just a small bony bump. Class 2 is longer but doesn't connect properly, maybe ends in a fibrous band. Class 3 is incomplete but touches the first rib. And Class 4 is a fully formed rib that connects up front, like a normal rib would.
And what was the mix in this study?
It was pretty spread out. They had 25 Class 1s, 17 Class 2s, 5 Class 3s, and 23 Class 4s that they operated on.
So the approach seemed to work for all sorts of cervical ribs, from little nubs to full ones.
Looks like it, yeah.
The paper mentions they found over 100 cervical ribs in total, but only did 70 operations? Why the difference?
Right, good point. They identified 105 cervical ribs across these 56 patients. So 56 were the index ribs, the ones causing the symptoms that brought the patient in.
Okay.
And then another 49 were found on the other side, the contralateral side. Many of those weren't causing any problems, so they weren't touched.
Ah, so some people had them on both sides, but maybe only one side was symptomatic, or sometimes both.
Exactly. They only operated on the 70 ribs that were actually causing the patient's symptoms, which means, yes, some patients needed surgery on both sides eventually.
Gotcha. What about the patient's general health? Were these, like, super healthy people otherwise?
Actually, no. And that's an important point the study makes. About 27%, so more than a quarter, had already had some kind of surgery before this.
Okay.
And even more, 62% had other medical conditions going on at the same time, comorbidities.
So this wasn't a group selected for being perfectly healthy.
Not at all, which, makes the good outcomes potentially even more meaningful. They happen despite these other issues.
Right. It reflects a more typical patient population, maybe. Okay, let's move to the surgery itself, the transaxillary procedure. What did the numbers look like? Time, blood loss, hospital stay.
Pretty good, actually. On average, across the 70 ops, operating time was about 141 minutes.
So a bit over 2 hours.
Yeah. Blood loss was minimal, average of just 47 milliliters. Very little. And the average hospital stay was only 2 days.
2 days is quick. Any difference between the nerve cases and the artery cases?
A slight difference. The arterial surgeries took a bit longer, maybe had slightly more blood loss, which kind of makes sense. But the hospital stay was the same, average of 2 days for both groups.
Okay. Now, the big question, especially when you're working near the neck and shoulder. Complications. Specifically, nerve injuries. What did they find?
This is probably the most striking finding in the paper, honestly. For this specific approach in their hands, they reported 0 identified injuries.
0. To which nerves?
To the big ones you worry about most. The brachial plexus itself, the long thoracic nerve that controls the muscle holding your shoulder blade flat, and the thoracodorsal nerve. 0 injuries identified to those.
That is really significant. Avoiding nerve damage is a huge goal in TOS surgery. Were there any complications at all reported in this group?
There was one issue mentioned. One patient had some temporary partial trouble with their phrenic nerve. That's the nerve controlling the diaphragm, your breathing muscle. But the key thing is, it resolved.
Okay, so one temporary issue that got better. Anything else? Bleeding? Infections?
Nope. They specifically reported no significant bleeding problems like hematomas, no issues with lymph fluid leaking, and no patients needing to come back to the hospital early after discharge.
And just to be super clear, that 0 major nerve injury finding applies specifically to these cervical rib operations.
Yes, the authors state clearly. No neurological or hemorrhagic complications were seen specifically in the operations done for the cervical ribs in this series.
Wow. Okay, that safety profile, especially for the nerves, is a really strong piece of data for this transaxillary approach.
Hmm.
What about longer term? How did patients actually do after the surgery?
They followed them for quite a while. The average follow-up was 591 days.
That's what, getting close to 2 years?
Yeah, pretty substantial follow-up.
And the results? Were patients better?
Overwhelmingly, yes.
Hmm.
The study found that 52 out of the 56 patients, that's almost 93%.
93%.
Yeah, 92.8% reported either complete resolution of their symptoms or just minimal symptoms left by the time of their last checkup.
That's a fantastic success rate. What about the other 7%, the 4 patients?
Those 4 still had significant symptoms that needed ongoing care, maybe pain management or further evaluation. And interestingly, they noted that these patients with persistent significant symptoms were only in the group that started with neurogenic TOS. None of the arterial TOS patients fell into that category.
Interesting. Did they have objective ways to measure the improvement besides just asking patients how they felt?
Yes, they used standardized scoring systems, the ones recommended for TOS research. Pain scores, for example.
Like 0 to 10.
Exactly. The average pain score before surgery was 6.9, so pretty high. After surgery, at the last visit, the average was down to 1.3.
That's a massive drop.
Huge reduction in pain. They also use something called the Kutik Day-Dash score. It measures disability, how much the arm, shoulder, and hand problems interfere with daily life.
Okay.
Those scores improved dramatically, too. Average was 60.4 before surgery. Higher score means more disability, and it dropped to 31.3 afterwards.
So both the pain scores and the functional scores showed really significant improvement.
Definitely. Objective evidence backing up the high rate of patient satisfaction.
Did they figure out if anything predicted who would do best? Like, did the type of cervical rib matter, or?
They looked into that, and maybe a bit surprisingly, they found that the specific class of the rib, class 1 versus class 4, didn't seem to make a difference in the final outcome.
Really? So a tiny rib spur or a full rib, the outcome was similar with this surgery?
Statistically, yes. Also, the patient's gender didn't predict outcome, and they mentioned the type of operation didn't either, which likely refers to whether it was just the cervical rib or maybe the first rib taken out at the same time, given the context of their database.
Huh. So none of those factors seemed key. Was there anything that showed a difference between outcome groups?
The one thing they did note, as we touched on, was that patients who came in with the arterial symptoms tended to end up with less pain and less disability at the final follow-up compared to the ones who started with the neurogenic symptoms.
Okay. And what about that point you made earlier that many patients had other health issues or previous surgeries? Did that make their outcomes worse?
That's another really key takeaway. Even though this group had a high rate of those other issues, the study found that simply having a symptomatic cervical rib was actually predictive of an excellent outcome after this surgery.
So if the rib was the problem, fixing it worked well, regardless of other stuff.
Pretty much. That 92% improvement rate held up despite those comorbidities in prior operations. It really suggests that if you identify the specific anatomical cause, the cervical rib, and you address it with this transaxillary approach, the chances of success are very high.
It pinpoints the value of targeting the right anatomical issue. Okay, let's pull back a bit. What's the overall importance of this study? How did it change things, or what did it contribute?
Well, the authors argue its main contribution was providing this really detailed picture of a large group of patients undergoing surgery just for cervical ribs using just the transaxillary approach. It covered everything from how they presented, how they were evaluated, how they were managed, and crucially, the surgical outcomes.
So it kind of set a benchmark for this specific procedure.
Yes, they effectively say it defined the transaxillary approach for cervical ribs by providing this level of data on a significant number of patients.
And using those standardized measures, you mentioned the SVS guidelines, quick-age, pain scores that helps other surgeons compare their own results, right?
Absolutely. It moves the discussion from, I think this works well, to here's the data from 70 operations using standardized metrics. It gives everyone a solid reference point for comparison, whether they're using the same approach or a different one.
So if you had to boil down the main conclusion from Jellebert and his team,
their bottom line is pretty clear. This series shows that using the transaxillary approach to remove cervical ribs, and sometimes the first rib too, leads to excellent results for patients with very few complications.
And they felt confident identifying who would benefit.
Yes, they reinforce that finding a cervical rib on imaging, having a positive response to a diagnostic scaling muscle block.
That test where they numb the neck muscle.
Right. That test, plus having abnormal nerve test results like EMGs or nerve conduction studies, those things together are reliable signs that surgery is likely to help significantly.
Okay, so wrapping up this part of the deep dive, it seems this study makes a strong case, based on a large cohort and good data, that the transaxillary approach for symptomatic cervical ribs is not only very safe, especially concerning nerve injury, but also highly effective in relieving symptoms and improving function.
It really does. And it underscores the value of these kinds of studies, large patient groups, standardized methods, detailed outcome tracking. Even for surgeries that aren't brand new, this kind of rigorous look can really clarify the best way forward.
It also makes you think about that history we started with, doesn't it? How Dr. Roos suggested this approach back in the 60s because he thought it might be better. But tradition kept the older method dominant. And now, decades later, a study like this comes along with the hard data supporting those potential advantages, especially safety.
Exactly. It shows how important it is to keep questioning, keep collecting data, and be willing to revisit established practices when the evidence points towards a potentially better way, even if it's less familiar.
It's a great example of evidence potentially shifting surgical practice over time.
Yeah, it really is. Sometimes you need that robust data to validate an approach that might have been overlooked or underutilized.
Well, thank you for sending these sources over. This was fascinating, tracing this story from an 1800s observation right through to this detailed 21st century surgical study, clarifying a long-standing question.
Always interesting to see how medicine evolves, builds on itself, and sometimes circles back with better tools.
And for you, listening in, maybe this prompts a thought. How often are established methods chosen simply out of familiarity? It makes you wonder what other potentially effective, maybe even safer techniques might be out there just waiting for a study like this one to really demonstrate their value and bring them into more common practice. We hope this deep dive gave you some good food for thought on TOS, cervical ribs, and the transaxillary approach. Keep those sources coming.
Until next time, keep exploring.